you might be blinded by the light. It's the case of a 70-year-old patient who came in with a systolic murmur and no symptoms. And I'll show you the echo. Okay, and I think most of you will already note what the problem is. Here is the mitral valve. Okay, just show you the mitral valve here. Okay. Okay, the mitral valve. Keep in mind the question was, what is the cause of her murmur? This is the image of tricuspid mitral regurgitation. It's a meso to late systolic form of mitral regurgitation, as you can see from this image here. But does it really explain her systolic murmur? Here's a tricuspid regurgitation, as you can see. Okay, and now my question. What else do you see? Okay. Mitral regurgitation is clear. We have a mitral valve prolapse. Do you see an atrial septal defect? Do you see a mass in the right ventricle? Maybe someone saw regional wall motion abnormalities or a thrombus in the left atrium? Or is there nothing else? I mean, it could very well be, because sometimes I trick you into believing that there's a pathology when there actually is not. Okay. You have to vote quickly, because I'm going to close this very soon. Okay. 5 more seconds, then I'm closing this. Oops. Okay, so the results are here. More than half of you think it's an atrial septal defect, and 36% of you think there is nothing, and 10% think there is regional wall motion abnormalities. Okay, well, the answer is exactly in this image. If you look at tricuspid regurgitation, you should also see that there is a jet from the left atrium to the right atrium. This is an atrial septal defect. You should pick this up. Of course, you can use an image view which helps you look at the atrial septal defect even nicer or better. This is a slanted view where you see the jet very nicely here. But I think the main part, and this is the reason I'm showing this case, is you have to always be aware that you could find something aside from the main pathology. So don't be blinded by something that you see, but go through the entire exam and look at all the different portions of the exam and then come to a final conclusion. Because, as I said, some patients don't only have fleas, they might also have mice and fleas. So here is an example of a patient with an atrial septal defect. Let me just show you 2 more other things that could point to the right direction. First of all, the right ventricle does look dilated in this patient. Third, you have a lot of flow across the pulmonic valve. If you pick that up, then you would also maybe come to the right diagnosis. What should we do with this patient? Well, since right ventricle is dilated in this patient, the patient needs an occlusion of the atrial septal defect. And I will just give you the information that this patient actually did have a TE study where the defect was measured with 1.1 centimeters, and she will receive an ASD occluder shortly. Okay, so Anna also noticed that the right ventricle is truly dilated. She made the right diagnosis as well. So I think all of you actually really, I must say, are really good. You know, I see there's a whole group of you who are constantly coming to these webinars, and I hope you will stay with us. And I really note that you're starting to involve yourself more and more with these cases. And actually, you're really good. Really, I must say, I'm very happy that this is also maybe something that is helpful to you, and that you are really working on this. Okay, I think I just see there's another question. Is this an example of heart failure with normal ejection fraction? Case 1. Case 1, let me go back. What was that? What was case 1 again? Well, actually, no. I think the first case was probably not a case of heart failure with normal ejection fraction. It was a case of left ventricular dysfunction because the patient did have regional wall motion abnormalities, and he had all reasons to have dyspnea because left ventricular function was reduced and because he had elevated left ventricular filling pressure. Case 2, Yvonne wants to know if how about the mitral regurgitation? Is it due to MI or coexisting in the case 1? Okay. Well, I think in this case, regurgitation was not very much. And since the regional wall motion abnormality, as we saw, was more in the anterior region and not in the inferior region, I would say it was not associated directly with the infarct, but it could be associated maybe with the mildly reduced left ventricular function. So I would say maybe to a minor degree. And then there's another question. Pericardial effusions to case 2, not indications of dysfunction in this patient. What was case 2 again? Let me see. I forgot. Oh, that was the toxic effects. Well, pericardial effusion in patients who have chemotherapy, there's 2 possibilities. One would be that it is directly linked to the chemotherapy and to left ventricular dysfunction, especially to right ventricular dysfunction. And the second possibility is that it's due to infiltration of the pericardium by the tumor. As a matter of fact, not all patients who have pericardial effusions really have a pericardial involvement of the tumor. Very often it is associated with chemotherapy. So in this case, only biopsy could tell what the real answer is. But my guess would be that it is not associated with the tumor itself, but just more with the chemotherapy. As a matter of fact, as far as I remember, the pericardial effusion was gone then after the follow-up study. And Emmanuel has a thought just about TAVI to restore aortic flow and somehow improve ventricular function, at least for some time. Yeah, very good comment. TAVI is certainly something that one could consider in such patients. Honestly, I think, I still had the impression that in reality, the aortic stenosis was not the primary problem, but only an associated problem. And the reason I think so was because I've been following the patient for many years, and at the beginning, her aortic stenosis was fairly mild for sure, and her left ventricular function at that time was still okay. So at that time, her function was still, I would say, reduced, but aortic stenosis was not severe. So I think that the aortic stenosis was not the primary problem. But maybe it would have been an option, at least maybe I mean, in retrospect, it maybe was the better option. Anything is better than what is happening at the moment. But yeah, good comment. Case 3, do you think the patient go for MACE procedure with, well, yes, that's what the patient did. She also had a MACE procedure. She had both the tricuspid valve repair and the MACE procedure. Just to wrap this case up, the only problem she had after the operation was it was done minimally invasive, and she had a problem due to the surgical procedure, which unfortunately went a bit more towards the breast, and she had hematoma there. That was the problem that she suffered from most, but she was doing fine afterwards.